What's intriguing, I think, for a lot of people is they assume that it's always a cholesterol problem. They assume also that if we fix cholesterol, that we're done. And the reality is that's not always the case.
What we've come to recognize is that about half the patients who have heart attacks have normal cholesterol levels, either naturally or through treatment.
Some people can have extremely high cholesterol all of their life and never have a heart attack or stroke. And other people can have very low cholesterol and have buildup. It depends on how inflamed that lining is and how well it's functioning.
We know that events happen because of inflammation in the arteries. We now have the technology to detect that inflammation and prevent the acute heart attacks from even occurring, prevent the acute strokes from even occurring.
We are doing more sophisticated testing that can really identify inflammation, and that's made a big difference in picking people out. These tests, these blood tests, can really help us to identify who is at higher risk.
There are really two aspects of heart disease. There's the injury, which is cholesterol, and then there's the response, which is inflammation. You can have very low injury and still have a massive response. And that's probably most likely when we hear about these surprise heart attacks or strokes.
Many studies have shown this, is if you have a good cholesterol level and a good inflammatory panel, you have very low risk. If you have an abnormal cholesterol level, you have high risk. If you have an abnormal inflammation panel, you have high risk. But if both are abnormal, you have yet more risk. And so it's really the combination of lipids, cholesterol, and inflammation that really allows us to fully risk stratify that patient.
My father passed at 65, and I want to live longer than that. That's just 4 years from me now.
I got a 6-year-old and a 5-year-old, and my wife is always saying, you need to take care of yourself. I want you to be around for a long time, so I'm trying to do my best to make that happen.
We worry a whole lot about breast cancer, and we don't worry about what's beneath our breasts. We have pink t-shirts, we don't have red t-shirts. And suddenly, in front of these numbers, were results that showed me this is real and it's me. It's happening to me, and it's happening now.
The most frequent tests that we order on a patient are the inflammatory labs, because the technology that we can utilize in laboratory medicine clinically is amazing. We can know if the treatment is working, then we can see the inflammatory labs are optimal, or we can see if we need to tweak the treatment to make sure the inflammation is mitigated in an individual patient. Like no other time before, we can individualize our care by embracing technology that's available to us clinically at our fingertips.
We can save more money if we can work on prevention and utilize some of these newer biomarkers of inflammation and combine them with other non-invasive techniques for lifestyle.
For those of us in primary care, one of the things we always worry about is who's going to have a heart attack, who's going to have a stroke. When am I going to get that call in the middle of the night that Mrs. Smith is in the emergency room? So it is forefront in our minds. Now it's no longer forefront in my mind because we have testing. Cleveland Heart Lab has a wonderful inflammatory profile that has advanced my ability to find the potential problem patients.
And it was the aha moment because I saw the numbers and I realized that, Even though I probably passed the lipid test, the big lipid test, I didn't pass all the smaller data the Cleveland Heart Lab tells you. And I was a believer.